And we're hoping you will call, actually, in our health focus segment of Talkback today. We're looking at one of those phrases that can be very, very scary. Pancreatic cancer. We have made so much progress over the last years and decades in so many cancers, but this one is a struggle. It's a struggle in diagnosis. It's a struggle in treatment. It's a struggle in dealing with those words when they are offered to you by a medical specialist, and it's a struggle for families. We've known in just the past few months actors who've died from pancreatic cancer. Alan Rickman, Denise Robertson, the agony aunt, the Apple boss Steve Jobs, of course, the actor Patrick Swayze. Many people whose celebrity has brought that condition to a new kind of platform in our public conversations, and we need to be able to talk about it sensitively but openly as well. We absolutely need to be able to talk about this openly, and we're hoping you'll call today if you're dealing with this condition as a diagnosis, if your family has dealt with it, if you're concerned about what the treatments are and how we can improve the diagnosis. That's what we're talking about today. We're joined by the surgeon, specialist surgeon Mark Taylor. Good afternoon to you, Mark. Welcome. Thank you for doing this. I know you're a very, very busy man. And Dr. Olive Buckley, who's a GP.
No.
We're not calling you that?
No, I'm not a GP.
We're not? Why did I call you a GP?
No.
I have no idea. Olive Buckley,
yeah.
Welcome. Good afternoon to you. And the reason we want to talk to you first is that you got the diagnosis yourself, what, a year ago or
exactly
just over
a year ago?
Right,
Nearly
exactly a year ago.
Yeah.
I don't know how to begin with that. When you hear those words, what do you think?
Well, it's like as if it's something out there. It's really alien, you know, whenever you do hear the words at first. But I think whenever you consider all the people that have got cancer of every variety, I think one must realise that you're nearly lucky to not get a cancer at this stage rather than unlucky to have to develop one. So I think you have to be very realistic about these things.
Many of us are going to deal with a cancer diagnosis. I mean, what is the figure overall, Mark, in terms of all cancers now? It's almost like 1 in 2 or 1 in 3 of us.
It's certainly
it's
as
that
close to
common
1 in
now.
3 in terms of all
pancreatic cancer, that has a different kind of tone to it, doesn't it?
Well, I really didn't know anything about it, and I work in the health service, and you know, it was sort of one of those words, but I never knew what the symptoms were. They were of... I just never bothered looking. You heard, you know, different, you know, ovarian cancer and all sorts of other ones where there were outreach programmes, you know, with GPs. But pancreatic cancer never came into my vernacular at all.
Did you have any symptoms?
The symptom that I presented with was jaundice. And there was no pain attached to it. I thought maybe it was gallstones or something like that. Went down to my GP and luckily... as he told me later, it was a bit of a red flag for him because I had jaundice with no pain. And he sent me down to A&E and they admitted me there into the liver ward.
So if it was gallstones, you'd have pain as well?
Potentially, yeah. So 8 days later, I walked out with the diagnosis of pancreatic cancer, and unfortunately I've got liver and lung secondaries as well, so it was a stage 4 as they would call it. So it leaves it that it's inoperable, and my route for sort of containment, shall we say, is chemotherapy.
What do you say in response to being told all of that? Do you ask questions? Do you just process it?
I mean, whenever you're given the diagnosis at the beginning, it's actually very difficult to think of the right questions. The questions come afterwards. And I think that's, you know, where the availability of specialist nurses and, you know, where there are, you know, doctors making themselves available to you, because things occur to you afterwards. They don't occur just at the time that you've been given the diagnosis, because it's just so out of the blue. But I think something that I've done personally, I had a couple of hours between leaving hospital and going home and meeting my partner to say, this is the diagnosis I've got.
Yeah.
And I had decided, I resolved in that period of time to say, do you know what? I'm living with this. I'm not going to die of this. And I decided that no matter what way I dealt with it, this was going to be head on, positive. Let's talk about it. Let's talk to everybody about it. And that would be one of the reasons why I'm here today.
It's not going to define you?
No, absolutely not.
Was that question in your mind, how much time do I have?
I never asked it.
You never asked it?
No.
And you've never asked it?
No, and I haven't gone looking on the internet to try and find out. Now, there have been different insurance policies and things like that that I've maybe had a look at. Yeah. And they would say to you, you know, oh, well, we would need a diagnosis, you know, that you're sort of within a year. Well, because it's such an obscure, abstract thing, you can't. How can you define when somebody's going to die? Anybody will give you that, you know, for the insurance company or whatever. So that's what I've based it on, but I really don't want to know.
Day at a time.
Yep,
Make
absolutely.
the best of every day that you have. That's the way to go. Yeah. Mark, how common is this?
Well, William, first of all, thank you for the opportunity to talk about pancreatic cancer, and I applaud Olive for having the bravery to come forward and talk.
Positivity is fantastic.
And the positivity is really the key message from this today. We see 250 cases of pancreatic cancer each year in Northern Ireland. It's one of the top 5 cancers that has a very poor overall survival, as you've explained already. Unfortunately, Olive demonstrates that presentation is often at a late stage, and that painless obstructive jaundice is a very common feature that we see with pancreatic cancer patients.
Is there anything we can do? We're going to talk about this more after the 1 o'clock news, of course, but is there anything more we can do to diagnose earlier, to give people an earlier start in terms of, rather than stage 4, stage 2 or 1?
Well, firstly, I think programmes such as this, highlighting some of those subtle symptoms. Olive has suggested that she became jaundiced, but actually when you chat to Olive, she had features of indigestion before that. Quite often, sometimes people have a new onset of diabetes, which is very unusual for them to have developed it when they don't have maybe other characteristics that lead to diabetes. So there are some subtle symptoms that maybe have been there before, and we need to raise awareness not only with our public but with general practitioners and hospital doctors.
Because I'm conscious, because I'm a bit of a hypochondriac, and I mean that in the clinical sense, but I'm conscious that you have to always say, when you've said just what you've said, Mark, those symptoms don't necessarily mean it's going to be pancreatic cancer. It could just be diabetes. It could just be indigestion.
Absolutely.
So if you're listening at home, don't be fretting about that. But if it's a prolonged symptom, speak to your GP, at least have that conversation. That's what you're saying.
Absolutely.
We'll talk more about early diagnosis. We'll talk more about new treatments and more about how we cope with this individually and as families when we come back. It's 1 o'clock.
William Crawley with Talkback on BBC Radio Ulster.
We're talking about pancreatic cancer until 1:30 today with our guests Olive Buckley and the surgeon Mark Taylor, and taking your calls on 030 30 80 55 55. We'll take your questions as well from Twitter at BBC Talkback and on our text line 81771 about how we deal with this. It's a remarkably difficult diagnosis and a remarkably difficult condition for medical specialists today. How do we deal with it? How do we prevent it? How do we get better diagnosis and better treatments, and how can we care for each other when we have that diagnosis? Mark, we were just talking before the news about early signs, possible early diagnosis signs. Is there anything we can do to make it less likely that we'll get pancreatic cancer?
Well, the theories behind the development of pancreatic cancer, like many other cancers, have risk factors associated with them. And, you know, we have to mention that risk factors associated with pancreatic cancer include cigarette smoking, alcohol, the development of diabetes. So diabetes may increase your risk twofold of developing pancreatic cancer, but similarly, pancreatic cancer may manifest as a new onset diabetes. So it's a double-edged sword in many ways.
And how can you tell the two apart if someone presents with some symptoms? Is there a simple test for pancreatic cancer?
Therein lies another dilemma, William, and that is that in terms of the exact way to diagnose pancreatic cancer, there isn't one ideal tool. In fact, quite often, and Olive will have experienced this, you go through a multitude of investigations, starting off with a very simple set of blood tests, followed by an ultrasound scan, and then leading on to a CT scan, and even in some cases an MRI scan. Ultrasound traditionally has not been a good tool for picking up tumours within the pancreas, particularly within the body and tail. So for your listeners, the pancreas is shaped like a fish. It's got a head, a body and a tail. Jaundice is associated when the tumour or the cancer is in the head, and as Olive described, painless obstructive jaundice. Quite often, if you've pain with jaundice, you may well have gallstones, and it's very innocent and nothing to worry about. But if you develop dark urine, very pale or putty coloured bowel motions, jaundice in the eyes, and quite often that's a loved one or a friend who notices it. And at the same time, very little in the way of pain in the abdomen. To general practitioners, that is a red flag set of symptoms that are mandatory for us to investigate in the hospital environment.
Are you confident that our GPs are noticing those symptoms in that batch and are referring at the right time, as early as possible?
I think that the introduction of red flag symptoms have certainly helped. And actually many of our charities, including Pancreatic Cancer Action and Pancreatic Cancer Research Fund, Pancreatic Cancer UK, run very many postgraduate courses for increasing awareness for general practitioners.
How long did it take you, just remind us, Olive, how long did it take you to get the proper diagnosis?
I was very lucky. 8 days.
Just 8 days. I mean, that's quick. Is that quick in the timescale you're describing?
Yeah, because Olive had very classical obstructive jaundice symptoms, and that would be, to be honest, William, and again, not wanting to cause anxiety to people, but if you have that painless obstructive jaundice with the dark urine, pale stools, in our profession, that's a tumour until proven otherwise.
Yeah.
It won't necessarily be in all cases, but that's the mantra to look at. It's tumour until proven otherwise.
And when you look back, Olive, I imagine you wish you had gone to a GP earlier with some of the other signs that you didn't recognise at the time.
Possibly, but they were rather obscure. You know, what I noticed was, you know, come bedtime, I found that my dinner hadn't been properly digested, but I would have eaten about 8 or 9 o'clock at night. So what I did was I moved my dinner time forward to 6, half 6, 7, and then I found that, you know, so I masked it nearly by adjusting my lifestyle.
And was that a daily thing? Pretty much?
Probably, yeah.
For quite some time?
Yes. Yeah. But nothing, because there was no pain or anything associated, there was nothing that caused me enough concern to actually go to the GP. It was the jaundice was the first thing that showed.
Mark, when you say obstructive, what do you mean?
So obstructive means that the bile duct, which is the tube that runs from the liver down into the bowel, that drains the bile that the liver produces, obstructive means that bile duct becomes blocked. And the blockage then leads to the person becoming yellow, and in pancreatic cancer that tube becomes blocked because the tumour grows into it. But the difficulty, William, and you can see the difficulty for our general practitioners, Olive has said symptoms were vague. When one becomes jaundiced with pancreatic cancer in the head, unfortunately, resection or taking the cancer away is only possible in about 25% of people. So at that stage, the tumour is at an advanced stage, and that's where trying to find earlier markers in terms of urine testing, looking at risk groups. We mentioned people with alcohol, smoking, family history. We're learning more about family histories and hereditary pancreatic cancer.
There's some evidence.
And there's some evidence even in terms of the BRCA gene, which you'll be familiar probably with in terms of breast cancer.
Yeah.
So because our prognosis has not changed in 40 years, and I can sit and say today that we can manage colorectal cancer going to the liver. We have fantastic 5-year survival. In fact, most tumours now, you can see a 5-year survival of over 50%. Unfortunately, in pancreatic cancer, it's 5%, and that hasn't changed.
You look at the revolution that's happened in HIV and AIDS, for example, we're practically beating that now with the new medicines and everything. And in 40 years, we haven't made much progress with pancreatic cancer. It's not just an issue for the medical profession, obviously, who we depend on in these things, and for those who have received a diagnosis like Olive, but also their partners, their loved ones, their family members, the circle around people dealing with that. They're dealing with it too. Kerry Irvine knows exactly what I'm talking about. She's in our OMA studio. Kerry lost her husband Noel to pancreatic cancer in November 2001, was it, Kerry?
2011.
2011.
Yeah.
Excuse me, 2011. And how long was the diagnosis and survival period in your case, in Noel's case?
Noel had been going to his GP for about 18 months prior to being diagnosed. He was being treated for irritable bowel syndrome. He was eventually diagnosed in April 2011, and he passed away in November 2011.
Devastating for you.
To say the least,
yeah.
Yes. We Noel did ask the question. I know Olive said she hasn't asked the question, but Noel did ask the question because we have 2 small children. Ellie was 5 and Nathan was 8 at the time. So to him it was important to, whilst he remained positive, he wanted to know how fast the clock was ticking, I guess. He was originally told 6 months. He fought and he got 7 months.
Yeah. And he did ask the question.
He did, yes. I think it was more for the children. We made an awful lot of memories as a family during that time. And it was for their sake, I think, that he asked the question more than anything.
Would you say you're still dealing with this now, Kerry?
Yes.
Yeah.
I fundraise and raise awareness quite a lot.
And that keeps the positivity in your life, I suppose, that focus.
Without a doubt.
Yeah.
We found as a family very isolated. There wasn't a specialist nurse in the Mater Hospital at the time that Noel was diagnosed, so we have a very different story, I guess, to people going through the hospital and diagnosis now, thankfully. But there's still a lot of work to be done, raising awareness. GP training is massive. I helped set up a fund in Noel's memory, Action for Noel, that any money fundraised here in Northern Ireland stays in Northern Ireland, and our focus is early diagnosis and training GPs.
How do you explain, Mark? Kerry, just stay with us, but Mark Taylor's here. I know you know Mark.
Yes.
How do you explain, Mark, why some people, when they're given a diagnosis, and I've met people with 3-4 year survival rates, and others 9 months, and others, I don't know what the variety is. How do you explain the difference, the diversity of survival rates?
Well, I think, firstly, whenever a patient asks about survival, the important feature is that what we say is based on the average for the population with that disease. Yeah. So an average survival, and as you know, William, survival follows a normal distribution. So there are people at one side of that average and people at the other side. You've made a very important point, which we're looking at in terms of research, not only in the university, Ulster University, but also in Queen's University, and that is, are there different subsets of pancreatic cancer? Are we seeing those people with a very aggressive tumour that literally from diagnosis to passing has been a number of months? Because we all in our practice have patients where we've maybe on being asked, and I think that's an important point, no clinician should force a prognosis onto a patient. It should be at their request, and we have to say that it is an average. It's not a statistic. And what I say to my patients is, I'm delighted that when you come back to see me at 2 years and 3 years that my statistic was incorrect. And that it's back to Olive's positivity. That
Get out there and beat me. Prove me wrong.
Important. Prove me wrong. And let's work at this together.
Yeah. John Callan, whom you'll know very well, Professor John Callan from Ulster University, is in our Coleraine studio. And John, welcome. Good afternoon to you. The research that you've been involved in got quite a bit of press just before Christmas last year. We've been talking about the difficulties in prognosis over the last 40 years, and not much improvement on this. But but the research you've been involved in has been hailed as a kind of first treatment breakthrough for something like 4 decades. Can you tell us about what you've discovered and what it might lead to?
Yeah, well, good afternoon, William, and hello to Mark, Olive and Kerry as well. As Mark alluded to there, the survival statistics for pancreatic cancer haven't changed in the last 40 years. And this really highlights the fact that the current treatments are proven largely ineffective. We've been investigating a new treatment called sonodynamic therapy. And this basically involves using sound waves, very low intensity ultrasound that we would use in diagnostic ultrasound scanners, to activate an otherwise non-active drug to produce a cell-killing agent that we call reactive oxygen species. And the main attraction of this treatment is that both the drug and the ultrasound itself, the stimulus, they're harmless on their own, but when they're combined together, they produce this potent anti-cancer effect. And we have shown in preclinical studies, and I stress that this is in preclinical studies, that when sonodynamic therapy is combined with an existing pancreatic cancer chemotherapy known as 5-fluorouracil, that we get a significantly improved tumour response compared to either of those two treatments by themselves, and importantly also when compared against the sort of benchmark chemotherapy drug that's used to treat pancreatic cancer known as gemcitabine.
Is this going to roll out into new treatments? Are we going to see this making a difference within the next year, 2 years, 5 years, 10 years?
Rightly so, there's a rigorous protocol for approving new drugs and treatments. But as I say, we're at the sort of latter stages of the preclinical development work. We're trying to secure funding, and we've had significant interest from several investors, etc. And also from we're applying to the likes of InvestNI to try and get together a preclinical package that we can present to the regulator, the MHRA, to get approval for a phase 1 clinical trial in this area. So realistically, we're about two years away from that time point.
John, how much money do you need for that kind of research, that kind of funding you're after?
Well, it's sort of in.
There might be a new minister sitting listening to this somewhere.
Yeah, well, we've estimated that the sort of first stage to get us to preclinical trials would cost around about £150,000 to £200,000.
Drop in a bucket.
Well, trying to get that
out of a healthcare system, we spend nearly $5 billion a year. In Northern Ireland alone. That's a drop in a bucket.
Yeah, and
to try and get some outcomes for pancreatic cancer here.
Another very important aspect as well is that pancreatic cancer only attracts 1.5% of the total cancer spend in the UK. And that's an extremely dismal
We may be
amount.
beginning to understand now why we're making so little progress.
Exactly.
Yeah, we may be beginning to understand this. How often, Mark, does a GP see someone in Olive's situation where they're looking at the alert? Is it a common enough experience for GPs?
Well, I think to answer that question, William, we have 250 new cancer diagnoses per year in a population of 1.8 million. So, again,
so common.
It's not so common. And for many general practitioners, what is very common is people with indigestion, people with upper abdominal pain, people with aches and pains, people with unexplained weight loss and maybe can't ascertain why. And again, we're back to that major dilemma of which person coming in is likely to or should be further investigated for pancreatic cancer.
Is it always weight loss, never weight gain?
It's generally in pancreatic cancer weight loss, unexplained weight loss.
A question here for you has been texted in from someone who describes himself as having type 1 male diabetes. How the symptoms, he says, can look the same from what you've just said. How can he tell the difference? The answer is he can't.
He can't. And I suppose just to clarify, the Pancreatic Cancer Action have certainly been trying to highlight a particular group of individuals. So people with type 1 diabetes, I'm certainly not saying today that if you have developed type 1 diabetes that you have or are at risk of pancreatic cancer. But what I'm saying is that we know with type 2 diabetes that someone who is overweight, someone who has a high cholesterol, someone who has hypertension, in other words, what we call the metabolic syndrome, they are at risk of type 2 diabetes. But if you have someone who is very fit, who doesn't have some of that portfolio of weight problems, cholesterol, etc., and they develop type 2 diabetes at the age of 50 or 45, what we're saying is just stop for a minute.
Let's take a look.
And take a look here. Is that simply that the person has developed type 2 diabetes for whatever reason, genetic, familial, whatever, or could there be some other reason? And that's one of the ways. It's not ideal, William, and I don't want to alarm listeners, and certainly someone with type 1 diabetes. What we're saying is because the pancreas is the place where diabetes comes from, because the insulin isn't working properly or isn't secreted, just ask the question at times in those that are outside the norm.
Is it this? Could it be something else? Let's investigate. Yeah, let's investigate. And if you're a rich person in the United States and you're having an MRI every year on your health insurance, you're probably less likely to be a late diagnosis, aren't you? That's just the reality of it. Hello, John. John's on the phone lines. How are you doing, John?
Good going, William. William, in December this year, I showed all the symptoms of weight loss, night sweats, pain sort of around the left-hand side. The doctor referred me on for a consultation in December, marked urgent. And I eventually got that consultation 2 weeks ago in May. or just at the end of April there, and I got a CT scan on Friday. Still waiting the results on it. But if early diagnosis is everything, why did it take so long?
6 months from
6 months.
from what looked like alert signs. 6 months, Mark.
That's it.
Oh my goodness.
I think
That can make all the difference, can't it?
I think that's what gives many medical practitioners sleepless nights, and that is the waiting lists and the difficulties with waiting lists. And the red flag system was brought in exactly to try and prevent such people such as John going on to a waiting list to be seen with symptoms that are concerning. And I suppose...
When was the red flag system brought in?
Oh, that's been in place now for at least 5 years.
5 years, but John's talking about last December.
And again, I suppose it depends...
Is that system working?
Well, I think, as you know, William, there are difficulties within our current system, and hence why we're going through various reconfiguration debates and discussions. But
John, you obviously don't think it's working.
Well,
if you had to wait 6 months,
I'm in trouble. I haven't got the results yet, but if the time's critical.
Yes, but the red flag system, John, it doesn't matter in the sense whether you're clear at the end of it all. You should have been seen earlier.
Yeah,
you definitely
exactly
should have been seen earlier.
That's right. That's exactly it.
And we hope you will be clear. We hope things will work out fine for you.
Okay, thanks very much.
John, thank you very much for calling. Chris is there too. Hello, Chris.
Yes, William. There is one thing that is constantly overlooked whenever cancer is spoken about, and it is cannabis oil. And I'd just like to get it out there, and just get it out there that I want people to go out there and have a look and research this, because the evidence is astonishing.
The evidence is astonishing that cannabis oil does what?
It treats so many things. Cancer is one of the many, many things it treats.
What, all cancers? Any particular cancers? What are you talking about, Chris?
I have a friend from Mumma called Kieran.
Well, let's not give out your friend's details, please.
Sorry, but he doesn't mind.
I know, but I do. I don't want to give out personal details.
Okay, but he is treating himself with cannabis oil. He has a brain tumour, glioblastomas, and he's been treating himself now for over a year, okay? His last scan there, they had said it had actually frozen this tumour in its tracks.
Okay.
So these are very, very... one of the most serious tumours you can get is glioblastomas.
All right.
And they're renowned for being brutal.
Chris, thank you very much. I'll go to Mark on that. There are lots of reasons why people might go into remission, why tumours might change their progress and regress. There are lots of different reasons. Is there any evidence to suggest that cannabis oil can be effective in the treatment of cancers? Well, to your knowledge,
to my knowledge, William, I hear what Kieran's saying. I think that
Chris.
To my knowledge, certainly in the realm of pancreatic cancer and hepatobiliary cancers, I can't stand over publications that strengthen the use of cannabis liquid. I think that it is a sign that many of us are searching for answers, and as you know, if you go onto the internet, there are many treatments and radical diets and various procedures that are available.
But we also know this, don't we, Olive, that positivity, your attitude, your relaxation, dealing with anxiety, these things are important. Mm-hmm. They can affect your outcomes.
Absolutely. It's the day-to-day, because that's what I'm living, is day-to-day. Yeah. And I try and live it as well as I possibly can. Some days I get down, but I shake myself and get on with it again, and just get out, talk to people, be with your friends. Don't hide away. Don't hide away by any chance. There's no need to be ashamed of having cancer.
It's
absolutely not. Absolutely not. Talk to people about your symptoms, even if you have got little things that you think. Talk to your friends about it, because somebody knows somewhere. That to refer you. It happened with a friend of mine, a delivery man coming into her workplace, suddenly developed this jaundice. She told him, go to your GP.
Always go to your GP when you get jaundice.
He was diagnosed.
Always. Mm-hmm. Yeah. It's obvious, isn't it? Yeah. Sean. Hello, Sean.
William, that's a very good programme you're running at the moment.
Oh, thank you, Sean.
It's brilliant. I had a friend, and I hadn't seen him for about 2 months. And I met him one day, and I said, listen, you've lost a bit of weight. Are you on a diet? He says, no. He says, I'm eating away. I'm eating plenty. So, again, I didn't see him for 6 weeks or more. Met him again. He'd lost more weight. So I said to him, you're sure you're not in a diet? He says, I'm eating away. He says, I've been to the doctor and everything, and can find nothing wrong. And it wasn't very long after that until I was told that he had a tumour the size of a rugby ball. He had got some expert opinion on it or something. Now, I was told it was pancreatic cancer. I called with him, and 2 days later, he was up in the matter, had an operation, and from what I understand, it's been very successful.
Okay, that's good news. He's had the tumour removed.
Could you just say one other thing, William? They talk about research at your university and funding. I think the problem is it's not seen as a health problem. They will not fund it because they see that as an educational issue.
Okay. Thank you very much, Sean. And thanks to Olive Buckley and to our surgeon specialist here, Mark Taylor, and to John Callan as well for a little bit of an update on the research. I'm going to give our final call here, if I can, to Grania O'Neill, who lost her mother, Annie, to pancreatic cancer in January 2014, Grania, wasn't it?
Yeah, hello, William.
How are you doing? And I know last night you won the Armagh Banbridge Craigavon Council Volunteer of the Year award because of what you've been doing to raise awareness and to build support. What prompted you into that? I mean, obviously, some people react differently to the loss of someone they love deeply.
Yeah, definitely. I think the most shocking thing when Mummy was diagnosed was the survival statistics. It was just terrible reading them. She was given the diagnosis of 4 to 6 months, and I think solely down to her positivity, like Olive, that she got 7 months. But it was just shocking, and it was really, really, you just went through a mix of emotions, angry and bitter, and so I think that was just my calling for, okay, I need to make a change here, and we decided to start fundraising from then.
And this is essentially you shouting from the rooftops, isn't it?
Yeah, I've went a wee bit mad at times trying to get the awareness and stuff, but it's just something I'm so passionate about because at the end of the day, this disease claimed the life of my mum, and that's something that I'll always feel very strongly about.
Right.
So we've been doing a lot of fundraising over the last 2 years, and we've raised over £40,000.
Grania, congratulations. Thank you very much. And I hope that is actually effective in shouting from the rooftops. We need to work together on this as a community.
Definitely.
We need to look after each other. We need to get more funding. We need to celebrate the doctors who are doing such great work and the families who are caring for people who are going through it as well. And as Olive says, we need to talk. Just be open, transparent, be shameless. There's no shame in this. Let's take care of each other. All right, thanks very much, everybody. We'll see you tomorrow. Over to Hugo.